Assalamualaikum doctors. In this video, I am discussing about the management of Guillain-Barre syndrome (GBS). GBS is very important. It comes on history and also video stations. They can be show that someone doing the lower limb examination of neurology on the video. There is the child cannot walk, supported walk. These are okay. So first, what are the differential diagnosis of GBS we can be put? First of all, acute flaccid paralysis, any infection like polio, diphtheria and botulism. Then about the post-infectious autoimmune condition like GBS, transverse myelitis, these are. Then trauma, tumor we can keep and acute cerebellar ataxia. So polio, diphtheria, botulism, these are also included. Then first of all, I take the history. Examination of the child, of course. What is the examinations? ABCD, vitals, blood pressures, full neurology examination, cranial nerve examinations we need to do. Respiratory system examination we need to do, very important. Examinations, then some investigation we will do. First of all, lab CSF, cytoalbumin dissociation with high protein and normal glucose, no cells, negative culture. So CSF study we do cytoalbumin dissociations with high protein and normal glucose and no cells with negative culture. EMG, electromyography, we find the acute denervations. The nerve conduction velocity, that is slow. Antiganglioside antibodies GM1 and antibodies against the Campylobacter. Stool analysis we can do, imaging MRI of the spine to rule out the spinal cord lesions, X-ray of the pelvis and bone, tibia and fibula if unilateral. Bedside we do the blood pressure and ECG spirometry. So what investigation? Bedside, blood pressure, ECG, spirometry. These are very important. CSF study we do where we find cytoalbumin dissociation with high protein, normal glucose, negative cells. Then nerve conduction velocity is slow. Electromyography we can do which show acute denervations. We can do the antiganglioside antibodies. Stool analysis we can do, stool culture, antibody against Campylobacter we can do. Imaging MRI of the spine we can do, X-ray of the pelvis and the bone. Okay. Management purpose, what we do? First of all, admission to the ICU. Remember where in admission to the ICU, airway breathing and circulations, daily spirometry with FBC, forced vital capacity. Because respiratory failure is sudden and life-threatening, IV immunoglobulin we give, plasmapheresis we give, physiotherapy and rehabilitation, steroid if intermediate or relapsing course, chronic cases. Okay. So admission to the ICU, airway breathing, circulation, dehydration status, everyday spirometry, forced vital capacity, oxygen saturation, these are we check because respiratory death. Main treatment IV immunoglobulin, plasmapheresis and steroid in chronic cases, physiotherapy and rehabilitations we give. So this is the actually main treatment, and the multidisciplinary team we will involve first of all neurologist, pulmonologist, physiotherapist, occupational therapist, speech and language therapist, dietitian, ophthalmologist, cardiologist lies with the school, skin care for pressure ulcers. So what is the multidisciplinary team? My pediatrician consultant, neurologist, physiotherapist, speech and language therapist, occupational therapist, cardiologist, pulmonologist, very important, ophthalmologist. Squint is associated with GBS, lies with the school and the skin care pressure ulcer. Then what is the follow-up? Follow-up is with neurological examinations, cranial nerve examinations, spirometry and blood pressure measurement. What is the prognosis? Is poor because if there is cranial nerve affections, respiratory affection that requires ventilations, maximum disability at the time of presentations, bulbar affections and no improvement after 2 weeks. So what is the follow-up is spirometry, respiratory, blood pressure, ECG, these are. And the why not improving prognosis? First of all, maximum disability at the presentation, not improving after 2 weeks. Bulbar affections, There is respiratory compromise. There is these are cranial nerve affections. Why it is not polio? Because polio, no cranial nerve affections, asymmetry, no sensory affection, no autonomic affections, CSF, no lymphocytosis, nerve conduction velocity is normal in polio, isolation of the virus in stool. Okay. What is the causes of GBS? First of all, common organisms are Campylobacter, Helicobacter, COVID-19. Good. Campylobacter, Helicobacter, COVID-19. Preceded vaccination is oral polio vaccine, then meningococcal vaccine, rabies, flu vaccine. Remember, in GBS, vaccine history is very important because the vaccine sometimes meningococcal vaccines, oral polio vaccines, rabies, flu vaccine, these are preceded vaccine. Normally Campylobacter, Helicobacter and the COVID-19. Complications of GBS is I am telling respiratory failure, fluctuating blood pressure, arrhythmia, urinary retention and constipation. So what are the complications? Complications are respiratory failure, arrhythmia, urinary retention and constipations, fluctuating blood pressures. Okay, these are the questions. And another question they can be asked like, what is the difference between transverse myelitis and GBS? Transverse myelitis, it is sensory level due to infection and trigger and autoimmune demyelination of the nerves. So sensory level is affected. Thank you.